Hello, and welcome back to the Revenue Cycle Decoded podcast. I'm your host, Gina Cornett, and we are breaking down all things revenue cycle. In today's episode, we're going to talk about one of the biggest challenges in revenue cycle, and that is managing denials. And whether you're new to billing and accounts receivable or you've been working in it a long time, you know that denials can be one of the most frustrating aspects, but they're also a normal part of revenue cycle. And so with the right process, they are manageable. In today's episode, we're going to walk through a step-by-step guide to handling denied claims. So by the end, you will know how to identify denied claims, how to figure out why they were denied, what steps to take to correct and resubmit the claim, and then how to prevent denials in the future. So let's get started and turn those denials into dollars. The first step in managing a denied claim is to figure out which claims have been denied. And denials will come from your payers in one of two forms. So if you are billing your claims electronically, which most of us are these days, you are generally going to have your billing software or your clearinghouse flag those denied claims in an electronic remittance advice or an ERA. Now, if you are processing your claims manually, you may receive a paper EOB. That's kind of old-fashioned, but there are still a few, and that is an explanation of benefits, or you may also hear it called a remittance advice. And that will also include the denial details, just as an ERA would. Now, to stay on top of denied claims, you need to set up a system to review them daily. And most billing systems will allow you to generate a daily denial report. And this helps you to identify which claims need attention first and really want to focus on any denials that are going to be time sensitive. So if there's a very short time period for filing an appeal or rebilling that claim, you want to look at those. And then your high dollar claims, you really want to focus on those first. So before moving forward, let's clarify something. Denials happen after a claim is processed by the payer, but the payer has deemed the claim unpayable. A rejection, on the other hand, happens before processing, and it's usually due to some type of a formatting or a data error in the claim. So today, we're just going to focus on denials, and in another episode, we'll look at rejections. So denials, they are going to require corrections based on the payer's feedback on that ERA or that EOB. Now, every denial is going to include a denial reason code, which explains why the payer didn't pay the claim. And you will find this code on the ERA or on the EOB, and you'll hear them called CARCs or RARCs. And a CARC will be the denial reason code, and then the RARCs will add a little bit more information. So for example, we might have a code that is CO16, meaning the claim lacks information that's needed to adjudicate it, or a CO50, meaning a claim is not medically necessary according to the payer, didn't meet medical necessity, or a PR27, which means that coverage terminated before the service date. So the denial code is going to be your starting point for resolving the issue. Now, if you're not sure what a denial code means, there is a website, and I'm going to post it in the links below, and I'm going to flash it on the screen here, where you can click through to see all of the denial codes and what they mean. And that's your first step to figuring out what the reason is for the claim denial. Also, if the denial code isn't clear and you are pretty sure that you have all the information on the claim, but for some reason it's still giving you this denial code that doesn't seem to make sense, check the payer's portal or the manual for a detailed explanation. And by the manual, I mean the provider manual from the payer. For commercial payers, you may even need to call their customer service or your payer representative to clarify the issue. So, it's probably not going to be a quick call. Some of those calls can be fairly lengthy depending on their wait times and whether you get a good representative. And if you need further assistance, don't be afraid to ask for a supervisor because some of the reps are not as well trained as others. We'll just put it that way. So if you need additional assistance, run it up the chain and try to get to a good answer. Once you have identified the reason for the denial, it is time to categorize it. So categorizing the denial, we're going to try to put it into a bucket or into a category to help us know what we need to do next. So the categories would include administrative denials, and these are errors like wrong patient information or invalid insurance details or claim formatting issues. So maybe we put information in the wrong box on the claim. And then there are medical necessity denials. These are claims where the payer determined that the service wasn't necessary based on their criteria. And what it often comes down to is how it was coded on the claim. So I'll give an example. If you have a patient that goes in for a screening colonoscopy, but the first listed diagnosis is hypertension, that claim could get kicked back because why are we doing a colonoscopy for hypertension, right? So it's confusing their system and it's going to come back as not medically necessary. So we want to check our codes if we get a claim back for lack of medical necessity. Authorization denials. So this is something that's often missed. We either didn't get the required authorization or the required referral if our patient's in an HMO, or we didn't get that number on the claim in the appropriate box. So we want to make sure that we are obtaining those authorizations, number one, and number two, that we're entering the authorization in the appropriate box or the appropriate field in our practice management software so that it goes out on the claim. Another reason why we might get an authorization denial would be where we've performed more services than were authorized or more treatments than were authorized, or treatments or services outside of the authorized date, or it could be that we have authorized a service, but then we did something else. So we performed an additional service that wasn't authorized. Now, the next category is technical details, and this would be things like coding errors or missing modifiers or unbundling issues. So maybe we unbundled procedures that should have been bundled, or we didn't put on a modifier to indicate to the payer that the procedure should have been unbundled. So categorizing that denial will help you get to the right steps then to fix it. And this is where we really start the work, is fixing that denied claim. So the next steps that you're going to take are going to depend on the type of the denial. So let's go through them one by one. The first one is our administrative denials category. So we have key information that is either missing or it's incorrect. And so we're going to want to verify our patient's name. Do we have the right name? Does it match with what's in the insurer system? So if the patient is a junior or a senior, did we get that on the claim? If there's a middle initial, did we get that? Did we spell their name right? Did we get their date of birth right, or did we transpose numbers? And their insurance ID, did we get that right, or did we transpose numbers? Maybe they've changed insurance. So sometimes we'll get a denial because their insurance terminated. They switched to a different plan, different group number, different subscriber number, different payer, and we don't have the right one on the claim. It could be a coordination of benefits, so we don't have the right primary payer listed. And so we're going to have to bill the correct payer. So that's the first thing to check. Did we get our demographic and insurance information correct? So if we did not, if we find that we made an error, we need to update the claim with the accurate information and then submit the corrected claim. So we're going to ensure that all of our required fields are filled in before we resubmit it. And if we're submitting to a different payer because we have updated our payer information, again, we're going to want to make sure we've got all the information correct. For our medical necessity denials, there's several different ways that we may resolve these. The first one is we're probably going to need to look at the documentation and make sure that we coded the claim correctly. Do we have the correct CPT or HCPCS codes on the claim? Do we have the correct ICD-10 codes, and are they in the correct sequenced order to prove that the service was appropriate? Do we need to go back and look at the payer's policy or the Medicare local coverage determination and local coverage article to see what codes are covered? For example, if we're doing routine foot care and our patient does not have specific conditions that make routine foot care unsafe for them to do themselves, maybe we haven't documented any of those conditions, and therefore we don't have the appropriate modifiers on the claim to support medical necessity for routine foot care. If the patient doesn't have those conditions, we're not going to get paid for that. Okay. So those are the things we need to think about. Did we document according to the policy? Did we perform procedures and services according to the payer's policy? So first of all, for those medical necessity claims, we're going to review the notes. We're going to review test results, and we're going to review the diagnosis to ensure that they support the service or the procedure or the test that we performed. We may need to submit supporting documentation to show that we were justified in how we coded it. And so that may be physician notes or diagnostic images or lab reports. And we may need to submit appeal in this case. If we met all of the policy requirements and we coded the claim correctly, then we would want to appeal. So we would send an appeal letter to the payer describing why the patient needed this service, how we met the policy guidelines, how it's coded correctly, and that we should be paid. So there are many sample appeal letters on the internet, and ChatGPT can be really good to help you write appeal letters as well, but be sure that you do not use any patient identifying information because ChatGPT is not HIPAA compliant. So if you are trying to use it to help you write an appeal letter, let it write it, but then you bring it over to your HIPAA compliant system before you add in any patient identifying information to that. Just a word to the wise. So authorization denials, we're moving on. Authorization denials are common when we miss our pre-authorization or referrals. So we're going to use the payer's portal and try to confirm whether a pre-authorization was required. So all of the payers are going to have information on their portals on which services require prior authorization. And keep in mind, if your payer is Medicare, there are very few things that have to be authorized for Medicare. There are a few, but it's very limited. But for your commercial payers, your Medicare Advantage, your Medicaid, and workers' comp and liability, you are probably going to need some sort of an authorization. And if your patient is in an HMO, they are probably going to need a referral if you are a specialist. So look at the payer portal and see what services and procedures and tests require prior authorization, and medications as well. If it was obtained, but it was not submitted, then add it to the claim and resubmit the claim. If it was not obtained, or if you performed more services than were authorized, or if you provided services outside of the authorized dates, or if you had one service that was authorized, but the physician, when he was, for example, performing surgery, found that he had to provide a different procedure, then you can contact the payer. You can request a retroactive authorization. Now, not all payers will grant retro auths. Some will, some won't, but it's always worth a try. And finally, for technical denials, those are often due to coding errors or missing modifiers. So again, you're going to want to look at the documentation. Was it coded correctly? Was there a procedure that should have been unbundled, but we didn't put an appropriate modifier on it to unbundle it? So a 59 modifier or one of the X modifiers, perhaps. Did we code something that wasn't really there? Or sometimes the payers will actually downcode. So sometimes you have a 99215 and the payer downcodes you to a 99213 because they think whatever diagnosis code you submitted with that service didn't meet medical necessity for a 215. So you may need to submit corroborating documentation with an appeal letter to show that the service was actually justified. So again, we're going to review that documentation. We're going to identify if something was miscoded or missing. And if necessary, we're going to update our claim with all the necessary adjustments and supporting documentation if necessary, or we might appeal that claim. Now, there are a couple of other denial reasons. For example, our patient's no longer eligible for coverage. So in that case, we need to look for a different payer. Maybe the patient changed insurance, but they didn't tell us. Or maybe they simply lost coverage. So we may need to bill the patient. Or perhaps it was a service that we knew wasn't going to be covered by Medicare, so we issued the patient an ABN. We're just getting that denial from Medicare, and then we're going to drop that bill to the patient. Another reason we might get denied would be timely filing. If we didn't get our claims in on time to meet the payer's timely filing deadline, they're going to deny that claim, and we're really going to have a hard time appealing it unless we can show that we actually did submit the claim on time. So we're going to have to look for that proof that it was submitted on time, or we're just out of luck. Okay. So those are some of the things that we might see as far as denials and what we need to do about them. So once we have identified the reason for the denial and we've corrected the claim, then we're going to resubmit that corrected claim. And so here we really need to be accurate. So there is a corrected claim indicator. It is 7 for Medicare claims. For your commercial payers, you want to check their policy manual to see their rules for what indicator they want for a corrected claim. There also is the original claim number, the ICN or the DCN, and this links the corrected claim to the original submission. And then we want to ensure that all previously missing or incorrect fields are now populated and they are accurate. Because if we don't include these details, then we could end up with duplicate denials, and then we've got to work those. So double check everything before you get those corrected claims out the door. Now, to prevent future denials, every denial is a learning opportunity. So we want to use them to strengthen our processes and prevent similar issues in the future. We can analyze our denial reports for patterns and address recurring issues. Maybe we identify that over and over we're getting incorrect demographic information on our claims. This is an opportunity to retrain our patient access staff. Or maybe we are seeing a lot of medical necessity denial. So do we need to retrain our providers and our clinical staff on local coverage determinations and payer policies? Do we need to help them out with understanding how those claims need to be coded? Regularly update your team on payer requirements and coding changes. Make sure they're aware. Anytime we have coding changes that are going to be pertinent in your clinic or your department, your area of service, we want to make sure that they are aware and they understand those coding changes. And then review those claims for common errors before we submit them. If we know it's something that should have a prior authorization number, we should be looking for the prior authorization number on the claim so that we have it coded correctly and we can catch those mistakes early. So that's it. Managing denied claims doesn't have to be overwhelming when you follow a clear step-by-step process. Identify the denial, understand the reason, fix the issue, and resubmit correctly or appeal the claim. Or in some cases, you will just have to write it off or drop it to patient responsibility. So if you would like to learn more about managing front-end denials, and those are the denials that result from faulty front-end revenue cycle processes, those things that happen in the patient access space, I do have a course, Front End Denials Decoded, to help you learn to identify, manage, and prevent those claims using a team-based approach. And I would love for you to spend some time with me on that course. If you do, you have the opportunity to earn 2 CEUs from AAPC on passing successfully the end of course exam. So would love to have you join me there. And it is completely self-paced, so you can follow along at your own rate. And then any questions that you have as you take the course, you can feel free to post them in the Revenue Cycle Bootcamp Facebook group. And I'll be happy to answer them there. If you found this video helpful, don't forget to like, subscribe, and share it with your team. Let's work together to master denial management and keep your revenue cycle running smoothly. Thanks for watching, and I'll see you in the next video. Peace out.